IFR versus FFR. This seems like a question that has been around for a number of years now. FFR is the hyperemic measurement of a pressure gradient across a lesion to decide whether it's preventing flow to increase as much as it should. While IFR is also physiological assessment, but it's a measurement that is performed at rest. It does not need the injection of a hyperemic agent, be it intravenously or intracurrently. Now, at this meeting, two very important trials were presented on IFR and FFR. Two important randomized trials were presented back-to-back. IFR-SWEDEHEART, a randomized trial embedded in the Swedish registry, and DEFINE-FLAIR. Why are these two trials important? Because so far, IFR has done a lot of work, studies, comparing themselves to FFR. And by and large, you know, the same information in 85 to 90% of the cases. But the big criticism has been that IFR had no outcome data. So, you know, protagonists would say, since we are comparable to FFR, we have the same prognostic value and can be used for guidance, while the purists would say, well, you don't have an outcome trial. So this happened now, the disclosure of two important outcome trials using patients, large studies with patients randomized to either IFR or FFR guidance. The design of the trials was, interestingly enough, nearly identical, so it's randomized 1-to-1 to guidance for PCI or DEFIR, dependent on the result of IFR measurement or FFR measurement using the traditional cutoffs, 0.8 for FFR and 0.89 for IFR, the resting measurement. The outcome also was measured at 1 year with the same metrics, MACE, all-cause mortality, unplanned revascularization, and non-fatal myocardial infarction. These were by design non-inferiority trials. The good news indeed is that we have two positive trials that met their primary hypothesis, and IFR can be unequivocally declared non-inferior to FFR. We're talking about two large trials with more than 1,000 patients in each arm for the two studies. So importantly, if you look only at FFR, these two trials are doubling the evidence that is in favor of the use of FFR in terms of predicting outcomes, primarily actually unplanned revascularization, and at the same time, non-inferiority for the IFR guidance. If you look at the absolute levels of MACE events in the two studies, they're about the same, something like between 6 and 7% at 1 year, with no difference, no significant difference in terms of the three components of the composite endpoint. Also, of course, it's obvious, but it was nicely captured by design, more side effects or more subjective effects related to the adenosine infusion, of course, when you're randomized to FFR, which is an hyperemic index, versus the IFR, which is at rest. Perhaps one interesting observation also is that one study looked very carefully at the outcome of patients who were deferred to look for any difference in event rates between IFR and FFR. There was no significant difference, which is also reassuring. So great news actually for physiology in general and for FFR, because the level of evidence is doubled. You know, we had the two FAME trials and DEFIR, which were about 2,000 plus patients. Now we have 2,000 extra patients randomized to FFR with a clear link to outcome. Dr. Colombo, during the discussion, made an interesting comment. He said, if you're certain with IFR, no need to do anything else. If you are the border zone, perhaps you would give adenosine or even contrast. So he was suggesting that the hybrid technique that has been considered for some time could still be used in practice by many colleagues. So certainly cost-effectiveness analyses that we have not seen yet will also be important. Since the outcome is non-inferior with either guidance, cost, number of stents implanted, etc. will also play a role.